It is an honor to welcome you to today's webinar on good health and well-being and awareness in Parkinson's. This is organized by IMU Cares in close association with Malaysian Parkinson's Disease Association. And as we all know, Parkinson's disease is like a complex neurological condition that affects millions of individuals worldwide. And today we gather to shed light on effective strategies and advancements in its management. Throughout this webinar, we aim to provide you with valuable insights, practical guidance, and the latest research findings to empower patients, caregivers, and healthcare professionals alike. Together, let us delve into the realm of Parkinson's management, fostering greater understanding, support, and hope for a better future. And thank you again for joining us on this informative journey. And let us begin with the webinar, shall we? So before I actually begin, here are a few housekeeping rules. Upon joining this Zoom meeting, your screen sharing audio and video will be turned off. And I would suggest to keep your mics muted and your videos turned off for a smooth webinar. And during the webinar, should you have any questions for the speaker, you can always post your questions through Zoom Q&A chat box. And if you already see similar question to yours, please upload that question instead, and the most upvoted questions will be addressed first. And if you need any assistance, please approach our committee members. Our committee members have IMU members written alongside their names, so you can reach out to them. And please do remember to fill in the feedback form at the end of the session. It will take like around 5 minutes, and it will be really helpful for us to improve later on our webinar sessions. So here is our event agenda. I really hope we could stick to the timelines provided. However, if we do go overboard, I give you my sincere apologies for that. For 2 p.m. to 15 p.m., we'll have our opening session that we're having right now. And from 2:15 to 2:45, we'll have the webinar talk. And after that, we'll have a Q&A session where we'll be addressing all the questions that are posted in the chat box. And last but not least, we'll have a closing ceremony, and then we'll have the feedback session. So here is our speaker. His name is Datuk Sentraman Nagapan, and he's a clinical associate professor in internal medicine in International Medical University. And his email address is given below as well. So if people would like to reach out to our speaker, our honorable speaker, you can always do so via the email address mentioned here below. So what are the objectives of this webinar? So after this webinar, you'll be able to reflect upon the prevention of falls to improve general health and well-being, importance of maintenance of hygiene, and pro-health nurturing, and overall maintenance of a healthy life. And also, we'll all be focusing on the health screening tests and intervention. Now, before I move ahead, I think I'll wait for a couple of minutes for the speaker to join. And my sincere apologies again. It's just due to connectivity issues on the speaker's slide. Okay, so while we wait, I think we can look at a video that has been provided here on what is Parkinson's. So I think we could have a general overview of what Parkinson's is before we begin with the forum. Can you guys hear the video?
No, we can't.
Okay, I'll see what's up with that.
Hi, I'm Dr. Rachel Dolan, Vice President of Medical Communications at the Michael J. Fox Foundation for Parkinson's Research. I'm also a movement disorder specialist, which means I'm a neurologist with specialized training in Parkinson's disease, or PD. Today I'd like to discuss a question that is essential to our foundation's work. What is Parkinson's disease? Let's start with some basics. In the United States, it is estimated that anywhere from 600,000 to 1 million people or more are living with Parkinson's, and at least 60,000 are diagnosed each year. This makes PD one of the most common brain diseases, second only to Alzheimer's. Age increases the risk of Parkinson's, and the average age at diagnosis is 60. So as our population continues to grow older, more people are likely to experience PD. In fact, people tend to think of Parkinson's as an older person's disease, but some get PD at 40 or even younger. Some diseases can be diagnosed with a lab test. Cholesterol levels and blood pressure are measured to evaluate for heart disease, for example. We need tests like that in Parkinson's, but they don't exist yet. Doctors diagnose Parkinson's by completing a medical history and a physical examination. They look for two of the three classic motor symptoms, which are resting tremor, stiffness, and slowness of movement. When people hear about Parkinson's, they mostly think of these motor symptoms, especially tremor. But some people also experience walking and balance problems, and PD affects other body systems. Constipation, sleep problems, cognitive changes, and depression can occur, sometimes even before a Parkinson's diagnosis. And some people report that they lose their sense of smell. One of the hardest things about Parkinson's is that everyone with the disease embarks on a unique journey. In fact, movement disorder specialists say if you've met one person with Parkinson's, you've met one person with Parkinson's. Each person has their own mix of symptoms, and there is no standard trajectory or path. So if everyone gets their own version of Parkinson's, then what does everyone with PD have in common? To answer that, let's take a look inside the brain. In Parkinson's, the brain cells that make dopamine stop working or die. Dopamine is a signaling chemical, or a neurotransmitter, that coordinates movement as well as feelings of motivation and reward. When dopamine cells die, Parkinson's symptoms emerge. Exactly why these cells die is not well understood. Researchers believe that in most people, Parkinson's is likely caused by a combination of genetic and environmental factors. But although certain environmental factors, such as pesticides and head injury, are associated with an increased risk of PD, in most people there is no clear exposure we can point to as a straightforward cause of their Parkinson's. Similarly, while genetic mutations are linked to an increased risk of Parkinson's, based on what we know today, the vast majority of cases are not directly related to genetics. However, the field of genetics is moving fast. In Parkinson's, as in many other diseases, tremendous research is focused on genetics because this is our best opportunity to uncover paths to treatment breakthroughs. But how do we treat Parkinson's today? Here's what I told my own patients when I was a doctor in clinical practice. The currently available PD medications can't slow or stop the progression of the disease, but they can ease symptoms and help you continue doing much of what you have always done. The same goes for certain surgical procedures, which are a good option for some people. The most important point is that treatment regimens need to be individualized, so you should work closely with your doctor to determine what medication or combination of therapies work best for you and your symptoms. Speaking of doctors, our foundation urges people with PD to see a movement disorder specialist if possible. Many people don't get to these experts, and we'd like to change that because the right doctor can help optimize your Parkinson's care, update you on research and drug development, and direct you to clinical trials, which are vital opportunities for you to advance scientific progress. Specialists can help you build the right care team and treatment regimen, but there's much more you can do to feel your best, like making sure to eat well, exercise, and stay connected to others. Check out our full Parkinson's 360 toolkit for advice on living in the here and now with Parkinson's, as well as information on what to expect as Parkinson's unfolds over time. So, what is Parkinson's disease? Today, it's different things to different people, but by working together urgently and with purpose, we hope to make it a thing of the past for everybody. At the Michael J. Fox Foundation, our mission is nothing short of eradicating Parkinson's altogether. Much work remains to be done, but we've got many reasons to be optimistic. As Michael J. Fox says, the latest research is the latest hope. We're closer than ever to new and better therapies, even ones that could slow or stop the progression of the disease. And until the day we find the cure and close our doors, we promise we won't stop.
All right, so I hope that was an intuitive video on what is Parkinson's. Now I'd like to invite our speaker, honorable speaker, Mr. Nagpansan Raman, to present for Parkinson's.
Okay, good afternoon to every one of you. Let me have my okay, how do I get back?
So, do you need help?
Yeah, I need to get my presentation to share the screen.
Yeah, can you go down to the screen, shared screen at the bottom? Right at the bottom, you can see the shared screen.
Okay.
The green color button with the arrow facing
Cookies.
upwards.
Yeah, I see. I've come out of that one. I'm trying to get back into the Zoom. Right. Okay. More.
Once you are in share, once you click the share button, doctor, then you can
that's right.
see, yeah, so you can see a number of options. Share screen.
Yes.
Yes, you have started sharing. Yes, perfect.
Yeah.
Thank you.
Yes.
You can see a screen, yes.
Okay. Can
Yes,
you
we
get
can
my?
see.
Can you see the slides?
Yeah,
Okay, I might go to the slideshow.
you just need to put it onto presentation mode. Put on slideshow, yeah.
Okay, can you see it? Okay,
Yes,
fine,
we
huh?
can see.
You can see my slides, huh?
Yes.
Yes, we can see.
Okay,
Doctor.
good afternoon. Okay, good afternoon again to every one of you. You have just listened to a nice presentation on Parkinsonism. It's just the same which I'm going to more or less repeat. It's a neurodegenerative disorder. It's quite common. It's more common in men than women. I'm trying to just give you some sort of introduction or a primer on the structure of the brain. And thereafter, I'm going to tell you which structures are involved and what type of involvement. It could be a little bit technical at sometimes. Usually, if you see that this is the human brain, it's nicely placed inside the rigid structure called skull. And you have different parts. We call them anatomically, the front part of it is frontal lobe. After that, we call what is called parietal lobe. The most backward is occipital lobe. And on the sides is the temporal lobe. Earlier researchers, they were concentrating on the anatomy and trying to place some particular function to a particular part. For example, if you take the temporal lobe, then they say memory is a function of the temporal lobe, especially a part of the temporal lobe called a hippocampus. And then if that is damaged, your memory will be lost. So we were talking about an anatomical area and a specific function. But the current research points out areas of the brain are interconnected in a very complicated manner. So we now talk about networks. So a particular network connecting various parts of the brain is responsible for a particular function, like motor function, sensory function, so on. There is a part of the outside, we talked about the 4 lobes earlier I told. We need to know a group of nuclei, we call it basal ganglia, which is situated a bit deep into the brain. That's why I'm showing it here. And the one like a curved structure, we call it caudate. And there is, it just opposed to the blue structure called thalamus. Then the caudate is continuous the other side with structures called putamen. There's structures called globus pallidus externa, interna, subthalamic nucleus of lice, substantia nigra. These are technical terms, but these are structures included in what we call it as a basal ganglia or extrapyramidal system. This system
I believe the speaker is having poor internet connectivity issues, so we'll wait until he joins back. All right, so the speaker will try joining back because he has poor internet connectivity issues, as I mentioned earlier, and my apologies again, sincere apologies for all the mishap. All right, so the speaker is back here again. Can you hear me?
Yeah, I can hear.
Yeah.
Okay, so I think while we wait for the speaker, I would like to share a few thoughts from our side from what we have prepared as members. So I'll share a PPT as for now, and we'll discuss about the management of Parkinson's. So I hope it's visible.
Yes, Ibrahim.
All right, so
Okay, hi everyone, I'm Ethan from IMU. So today I'll be presenting about prevention of falls to improve general health and well-being. So there are two most common causes for falling for someone who has Parkinson's is poor balance, which is postural instability, and something called freezing. So freezing is when a person will suddenly, while he walks, he'll suddenly freeze in a fixed position and can't move on. So as Parkinson's disease worsens, a person can have a stood posture more frequently, and it increases the chance of falling forward. Next slide, please. Okay, so here are a few methods to overcome freezing. So first of all, we can use music. You can hum or sing a song while walking to the rhythm, so it can help you keep moving. Next is to try a metronome. By using a metronome, you can keep a steady beat, and we can walk to the beat, which can help reduce freezing. So we can also change the direction. So instead of moving straight ahead, which we want to do, we can always try stepping to the side first, or just take a step back and continue moving forward. So we can also shift your weight from side to side before attempting a step, because this can also help initiate your movement. Next is we can march in place. We can also lift our knees as high as possible before stepping forward. And then we can also move another part of our body. If like during freezing, our legs doesn't move, we can always swing our arms first, and then slowly we can try moving our legs again. Then we can also imagine a line that's in front of you. So we visualize the line, and you can step over it and follow the line. And if there are spots in the house that are always a bit tricky, like a doorway, you can always use tape on the floor to create a line to step on. And lastly, we can also use a laser pointer, which is around the same idea of imagining a line in front of you. We can step over the laser pointer line, and we can follow that. Alternatively, we can also ask for help or a family or friend to give us a gentle push. Okay, so this is a slide with some pictures showing our visual stimuli, where this visual stimuli would then go to spatial information, then spatial processing, and that can cause improved gait. So for auditory stimuli, it can help with temporal information, then temporal processing, and ultimately all of these will improve our gait. So somatosensory stimuli to temporal information and temporal processing. Okay, so these are the more general ways of how to prevent ourselves from falling. So first of all, it's very important to adhere to our recommended dosage of medication. So just some extra information is that both motor and non-motor systems can be helped by medication. It allows us to be more self-sufficient and stable. We can also think about large movements where such as for a person who has Parkinson's disease, you can notice a reduction in the motions. So while thinking of a larger movement, it's easier to take a few steps. So we have to focus on thinking about moving over obstacles or bridge or safety rails where large motions are required. The people with Parkinson's or their carriers can also remind themselves to take a deep breath before taking a big step or a big reach while approaching a curb or reaching for a rail. So next is exercise routinely. Some fall prevention strategies will be exercising to make sure our muscles are less rigid and to strengthen them. So these can help with the person's balance and increase our flexibility. Okay, so the next is to get frequent eye exams. This is very important because people with Parkinson's disease will have some vision changes. So it's good if we identify it earlier, and this can ultimately help us to fall lesser. The second last would be to keep our focus while we're moving. So it's important to always remind ourselves and know that might be mindful that we are moving. So our movements will be more coordinated and it will match our intentions. For example, they might turn their head and shoulders before putting their feet in the appropriate direction while when walking, and this could result in a fall. So focusing on making each movement precise and secure is very important. And the last one is to make our home safer. This is one of the most important ways because we can always clear a pathway for us to move easier and remove anything that might make us fall. Yeah, so that's it for this part. Does anyone have any questions? Okay, I'll move it on. I'll pass it on to the next speaker. Thank you.
All right, thank you. So now I'll be presenting the importance of maintaining hygiene. So firstly, we will talk about skin health. So dry skin is a common issue for people with Parkinson's. So we are basically trying to emphasize the importance of regular moisturizations to prevent the discomfort and complications. And we encourage the use of fragrance-free moisturizers or emollients to maintain skin hydration. So the focus areas you should try should be around the elbows, knees, and feet. For your urinary and bowel functions, Parkinson's disease can affect the muscles involved in urinary and bowel control, leading to issues like urinary incontinence and constipation. So good hygiene practices such as maintaining regular bathroom routines, staying hydrated, and practicing proper perineal care can help manage these symptoms and reduce the risk of complications like urinary tract infection. So, not to mention, like we also need to help with bathroom safety. So, there's also like an importance of installing grab bars and non-slip mats in the bathroom to prevent falls. So, you should also talk about raising the toilet seats and shower chairs to enhance safety and independence. And if you do have caregivers, remind them to help you like always keep it dry or ensure the bathroom is well lit and free of obstacles so that it prevent any like falling or yeah. Sorry, can you go to the next slide, please? All right. So next would be oral hygiene. So Parkinson's can affect oral saliva production, and so this can lead to dry mouth and increased risk of dental problems. So we should really try to emphasize the importance of regular dental care and oral hygiene. So we encourage you to brush your teeth at least twice a day with a soft bristle toothbrush and fluoride toothpaste. And not to mention to also use fluoride mouthwash and also flossing, if it's possible, and also to visit your your local dentist for dental checkups and to maintain oral health. Yeah. So for respiratory,
the chair, putting get too wet. They want to sit now.
sorry.
Ah,
Okay, I'll be moving on to respiratory health. So Parkinson's disease can affect the muscles involved in breathing, leading to shallow breaths and reduced lung capacity. So good hygiene, such as maintaining a clean environment, regularly washing hands, and avoiding exposure to respiratory infections, can help minimize the risk of respiratory illness that could further compromise breathing functions. All right, can we move to the next slide, please? So, for the prevention of infections, basically what we have to all keep in touch is that Parkinson's patients may have a weakened immune system and making them more susceptible to infections. So it is important to maintain the hygienes, like previously said, about your skin health, about your oral health, your respiratory health. Yeah. So by maintaining our good personal hygiene, we can it includes also like regular hand washing and proper wound care if we have any cuts or any lesions on our skin. And it's also important to keep away from people who are sick and try to avoid close contact with these people so that the risk of infections can be reduced. Yeah. And overall well-being, hygiene practices can contribute to a Parkinson's patient's overall sense of well-being. So feeling clean and fresh can boost your self-esteem, promote confidence, and improve the quality of your life. And it can also help manage the other symptoms such as excessive sweating or odor, which can be also common in Parkinson's disease. So moving on to secondary infections. So secondary infections, one of the leading examples would be come from poor hygiene. So because of the inadequate hand hygiene, you can have the spread of germs, and there's risk of perhaps respiratory or gastrointestinal infections. So meaning it will affect like your lungs and your digestive system. So proper hygiene practices, including hand washing and cleanliness in the living environment, can help prevent such infections and their associated complications. So next we'll be talking about drooling and facial hygiene. So drooling is drooling can be one of the symptoms you can see in a person with Parkinson. So what we would usually recommend is regular wiping of the face. So by using like absorbent pads or clothing protectors, and to also help like previously mentioned, the maintenance of dental hygiene can help manage this excessive drooling and maintain your basically maintain your cleanliness around your face. Yep. So as I previously said, body odor can be commonly seen in someone with Parkinson's. So so basically the increase in your sweat production and your gland functions can lead to this. And so then we could help reduce this by regular bathing or showering, along with the use of antiperspirants or deodorants. And yeah, and this would really just improve personal comfort and also the interaction you have with the people surrounding you. Yeah. So next will be psychological well-being. So good hygiene practices contribute to an individual's overall sense of well-being and self-esteem. So maintaining personal hygiene routine can promote a positive self-image, enhance self-confidence, and improve emotional well-being for individuals living with Parkinson's. Yeah. All All right, that's it for me. I'll pass it on to the next speaker.
All right, so thank you so very much for your presentations, people. So right now, I'll be presenting on pro-health nurturing and overall maintenance of a healthy life in Parkinson's. So what is pro-health nurturing? So proactively nurturing or pro-health habits and maintaining an overall healthy lifestyle is crucial for individuals affected by Parkinson's. And now symptom management, and there are a few key elements of pro health nurturing, which I'll be mentioning in the PPT today. So the first and foremost being symptom management. So engaging in regular exercise, such as aerobic activities, stretching, strength training, these can help improve mobility, balance, and muscle strength, as mentioned earlier. And these activities can contribute to better symptom management and enhance the overall quality of life. The second element to pro-health nurturing would be medication efficacy. Now, adhering to medication schedules and maintaining a healthy lifestyle can optimize the effectiveness of the medications. And proper compliance can also help optimize the effectiveness of the medication. And proper nutrition along with medication, exercise, and sleep can help reduce fluctuations in symptom severity and improve medication absorption as well. Apart from that, emotional well-being also plays a really big role in pro-health nurturing. And adopting healthy habits can positively impact emotional well-being. Now, exercise releases endorphins, and these endorphins can help alleviate stress, anxiety, and depression, which is commonly associated with Parkinson's disease. And hence, this is also a really important element that contributes to the pro-health nurturing of people affected with Parkinson's. And the fourth element being cognitive health. Now, a healthy lifestyle can also promote cognitive health and potentially slow down cognitive decline. And engaging in mentally stimulating activities like socializing or maintaining a balanced diet are all beneficial for brain health. Apart from that, there's also disease progression as an element. While Parkinson's disease is a progressive condition, a healthy lifestyle may slow down its progression, and hence the importance of all these elements in pro-health nurturing. And adopting good habits may delay the onset of certain symptoms and can improve the overall function. And I reckon that would be it about the elements of pro-health nurturing. Now we're going to talk about the health screening tests. I'll pass it on to the next person to talk about the screening tests.
So health screening test. So basically, screening test basically means like what we need to do to basically come up with a prognosis or diagnosis of Parkinson's. So that's really what we're trying to achieve here. So normally for health screening tests, we would start off with a relevant medical history. So we will test your physical and neurological performance, and as well review the symptoms experienced by the patient by a trained neurologist, which will help us to also diagnose Parkinson's disease. So next we have like this thing called single photon emission computerized tomography. That's a little technical, but yeah, it's basically a scan which usually supports the diagnosis of Parkinson's. Yeah. So other tests that we can use are familiar tests that I'm sure we've all heard about. It's like MRI scans, ultrasounds, and PET scans. So as well as other lab tests such as blood tests, and yep, these can help to rule out like other conditions that are similar to that Parkinson's, but it's still pretty new. Yep. So I mean, right? So here is an example of a DAT scan. So like as previously mentioned, so the DAT scan is the dopamine transporter scan. So you can see that the difference between the DAT scan of a normal patient and DAT scans of a person with Parkinson's. You can see that the areas that's illuminated is a lot lesser and it's a lot less bright compared to the person with a normal condition. Yeah. So anyone, I'll pass on to the next speaker to talk about the interventions that for Parkinson's.
All right, so I'll be talking about the intervention now. So the first intervention that we have is levodopa L-dopa, and this is most commonly prescribed in patients affected with Parkinson's, and it basically controls the symptoms of disease such as slow movements and stiff and rigid body parts. And patients who have been consuming levodopa for 3 to 5 years may eventually have restlessness, confusions, or unusual movements within a few hours of taking the medication. So these are like some of the contraindications of levodopa L-dopa. And changes in the amount or time of the dose will usually prevent these side effects. And the next intervention that we're going to talk about is Cinemet. So Cinemet is basically a combination of levodopa and carbidopa. And carbidopa component enhances the effect of levodopa. And this helps to mitigate the adverse drug reactions. So ADR basically is stands short for adverse drug reactions of consuming levodopa alone. And these adverse drug reactions include nausea, vomiting, and arrhythmia. An inhalable powder form of levodopa, which is also abbreviated as INBRIJA, and the tablet istradiflane, that is Nurians, have been approved for those experiencing off periods. And off periods can happen when Parkinson's symptoms return during periods between scheduled doses of levodopa or carbidopa. The next intervention that we have mentioned here is dopamine agonists. So the first line of treatment for Parkinson's disease, as they do not cause the long-term side effects caused by levodopa therapy, is dopamine agonists. And the reason, as I mentioned before, is due to them not causing any long-term side effects. Apart from that, these can be consumed on its own before consuming levodopa. And now these drugs act like dopamine in the brain, as the name suggests, and they include pramipexole, like Mirapex, or rotogotine, like Nupro, and ropinirole, like Liquid. And these can cause short-term side effects such as nausea, vomiting, dizziness, lightheadedness, confusion, and hallucinations. And the next intervention that we're going to talk about is anticholinergics. So these basically restore the balance between two brain chemicals, dopamine and acetylcholine. And these are two chemicals that are mediators that release in the brain for layman terms. And these aid in decreasing tremors and muscle stiffness in people with Parkinson's. And these medications can harm memory and thinking, especially in older people. And because of that, doctors rarely prescribe them in today's age. Apart from that, we have MAOI inhibitors. So drugs like safenamide, for example, Zadago, or seleginine, for example, Eldepril or Zelapar, or even perhaps razegalane, block the brain chemicals that break down dopamine and helps brain have more dopamine to work with. And the common side effects for this is that they might include nausea, dizziness, fainting, and even stomach pain. And studies of animals suggest that razegalane may also slow the progression of Parkinson's. Side effects include headache, joint pain, indigestion, and depression. Safenamide is an add-on medicine that may be prescribed when individuals taking levodopa and carbidopa have a breakthrough of Parkinson's symptoms that were previously under control. And the side effects here include trouble falling or staying asleep, nausea, falls, uncontrolled involuntary movement of the muscles as well. Last but not least, we have COMT inhibitors. For example, entocarpinone, for example, Comtan, or picarpone, like on Gentins, and talk upon as well, like TOS1. And when you take levodopa, a chemical in your body called COMT makes part of the drug useless. And these drugs block COMT so the brain can use levodopa more effectively, which eases Parkinson's symptoms. Thank you. This would be it about the PPT that I'm presenting. I believe Dr. Sunil also has something to present. So I would like to pass on to Dr. Sunil to present more on Parkinson.
Thank you, Brian. Thank you so much. Good afternoon. My name is Dr. Sunil. I'm an associate professor in the Department of Pathology at IMU. Give me a few seconds and I'll bring up my presentation. Essentially, I'm going to keep it very short, just to tell you more about the disease, and that will sort of give you a clear understanding as to why we do certain interventions in this disease, right? So just give me 1 second. Ibrahim, can you allow me to share screen, please?
Sure, Doctor. Hold on a minute. Are you able to share the screen?
It still is disabled, actually.
I think I've given you the permission, but I'll check again.
Because I get a message saying host disabled participant screen sharing. Maybe someone from Mpda can give me the access to present.
I believe being the co-host, I do not have the access to give anyone the permission to share the screen or not. Is it possible for you to share the PPT with me and I can try sharing the screen?
Okay, give me 1 second.
All right, sure. Although it does say on my side that all participants can share the screen.
Yeah, okay. I think I can do it now.
Yes,
Right.
screen.
I hope you all can see my screen.
Yeah, we can.
Yeah, we can see it.
Right. I'll just keep it very short. Yeah, Sethuraman was talking about the anatomy of the brain. So essentially, there is a portion of our brain which is called the midbrain, which is called a substantia nigra, right? And which is where a chemical called as dopamine is produced in our body, right? And dopamine is a very important neurotransmitter because it works along with another neurotransmitter called as acetylcholine, and essentially keeps our muscles and their tone in a very healthy way, right? And now you can see what happens in Parkinson's disease. The area that's essentially brown totally disappears, meaning which the cells which make this dopamine in our brain disappear for some reason, right? What exactly causes the cell death is really unknown, and essentially the things that we know is that Parkinson's is a very chronic progressive disease, right? Let me just move on to the next slide. Right. Okay. So just to show you what exactly happens, so you can see that this dopamine will work along with this acetylcholine to act on the spinal cord and help to keep our muscles in its normal state. Right. So in Parkinson's disease, essentially, when there is no dopamine, that will result in the acetylcholine still making its effect on the basal ganglia, which is a part of the midbrain. And this is the one that essentially will cause the muscle to become very tense, right? And result in something called as tremors. Right. Okay. So just to summarize, essentially, the dopamine is very important to help us keep our balance, to help us move normally, to prevent our joints from getting rigid and essentially not cause any tremors in the body. So you can see that the lack of dopamine, as that you would see in Parkinson's disease, makes our muscles very tense. Okay, so they, it's very tense, and often you'll find tremors. Okay, that start in the peripheries of the body. The joints in our body tend to become very rigid and stiff, right? And movement is generally tends to be very slow, right? So as I mentioned again, and I think our students have showed the various drug treatments. Okay, so most of the drugs that are prescribed in Parkinson's disease essentially only control what we call as the motor and non-motor symptoms. There is no treatment till date to actually slow the progression of the disease, right? And a lot of research is going on in terms of looking at various biomarkers where we can predict that, this patient is going to have Parkinson's disease, and we can do intervention at a very early stage. Right. Okay. So you will see that essentially people with Parkinson's, they are actually, they have stoop posture. If you look at their face, it looks like a mask, right? And they have tremors usually that involve their hands and as well as their feet, right? And they are unable to walk like a normal person, right? So they tend to take very short steps and have what is called as a shuffling gait. And if you ever see people with Parkinson's disease, unlike normal people who swing their arms when they walk, this is very drastically reduced in patients with Parkinson's. Right. So I put a list of features that we very often look in order to make a diagnosis of Parkinson's. I will not go through this or read this in detail. Essentially, because of the lack of dopamine, you will get something called as a tremor and something called as rigidity, right? The third and most important thing is difficulty in initiating movements. In medical language, we call this as akinesia, right? For example, patients will often find difficulty in starting to walk or rising from a seated position as when they're seated in chair, right? And as time goes by, they even find it difficult to speak. Okay, so when they do speak, the speech is very low and usually monotonous in nature. When they tend to write, the writing becomes very small, what we call as micrographia. Right. Number 4, the most important is there are a lot of postural changes. Okay, and these are all very clues that this could be an underlying Parkinson's disease. For example, they will have a forward posture, what's called as a stoop posture. They'll have difficulty in walking, so their normal walking style is disturbed. Okay, and they have what is called as a shuffling gait, right? And as I told you earlier, the swinging of the arm is usually reduced, right? In addition, they can have a lot of other features, right, which is very important to address, and also brings to the fact that Parkinson's is a disease that is not only treated by a physician or a doctor, but rather a team of people, right? So this could include a psychologist, a speech therapist, an occupational therapist, a physiotherapist, right? So there are a number of people, right? So essentially, managing Parkinson's disease is more or less of a teamwork. The most worrying thing is that Parkinson, as it progresses, will ultimately result in dementia, right? And that becomes another major worry, not only for the patient, but also for their caring members, especially the family. Right, so I'll just show you some pictures. It may look a little bit odd. You may have never seen this, right? These are all autopsy specimens of the brain. So you can see this is a normal brain on the left. This is the dark brown areas are the areas essentially that have the dopamine producing cells. The one on the right is from the brain of a person who had Parkinson's disease. You can see the brown areas have disappeared, right? And essentially, if you do look under the microscope, which is what I as a pathologist do, right, you will find the cells that actually produce this dopamine are lost, and you will find a lot of these so-called brownish pigmented cells, which have actually engulfed all these cells called neurons, which are actually producing the dopamine. Right. Another very important finding is something called the Lewy body. Essentially, what happens in Parkinson's disease is that there's a lot of changes at the cellular level, right? A lot of abnormal proteins are being produced. These get misfolded and they get trapped within the cells of the brain. So one of the most common findings is you will find something called as a Lewy body in the brain specimen. Right, I think that's the last slide. Let me just stop sharing and then I will. Yeah. Okay, so essentially what I wanted to emphasize is the fact that there is no cure for Parkinson's disease, right? So that's the thing that we need to face, right? But what can be done in terms of healthcare is that support can be given to patients, right? In terms of having a team of people who can essentially try to reduce the patient's symptoms and improve the quality of life. And as I mentioned, there's a lot of research going on at the moment looking at various markers which can actually predict the early development of Parkinson's disease. All right, so that's it from me. Thank you so much for your patient listening. If you do have any questions, please feel free to ask. There is one, but from Mr. Stephen Heng, it asks something about restless leg syndrome. Mr. Stephen, I would find it difficult to answer that question. I'm not a physician. Perhaps if Datuk Sethuraman was here, he would be able to answer. But restless leg syndrome is not necessarily related to Parkinson's, right? Okay, but we shall try to answer your question. And yeah, we'll get back to you on that question. Thank you so much for asking the question.
Doctor,
yeah.
Doctor, may I ask you about this Parkinson? How long will it take to deteriorate our health? Because I'm having it for the past 5 years.
Right.
I'm having my toes are curled. So basically on my left-hand side, I'm affected. But like what you said, the speech will be flaring. And so I'm going through all this gradually. So I roughly want to know how long will it take for a person to go through this?
Okay, to be very frank, it's very difficult to give a specific time period in which this will happen. In some people, the progression may be slow. In some, it may progress very rapidly. So So it essentially depends upon how soon all the the cells that are producing this dopamine are actually dying in the brain, and the fact that whatever medications you have is not able to control your signs and symptoms. So it's very difficult to say at this moment of time that it will take an X number of years for you to essentially get worse. But what I can say is you still need to continue taking the treatment. You need to seek help from a team of specialists who will essentially ensure that all your symptoms improve. Essentially, looking at the fact that they can improve your quality of life.
Okay. Thank you, doctor. Thank you very much.
Are there any other questions? If there are none, shall I shall pass it back to Ibrahim.
Yeah, sure, doctor.
Thank you.
Sir Nagapan, do you have anything to say before we end the session?
There were two questions. One is, how do you treat restless leg syndrome? Okay, not exactly as doctors professionally put it, a part of Parkinsonism, but it's quite common in patients with Parkinsonism as a comorbidity. Levodopa itself can control restless leg to an extent, but more often, most of the people try to use one of the dopamine agonists like pramipexole. That can also be very helpful. Coming back to these are the two drugs normally we use to treat restless leg syndrome. Coming back to the second question, Madam Jagadishwari was raising. Okay, you don't have to feel so desperate. We call, and the progression of the disease is something like we go into stages. It is a progressive disease. It doesn't stay at one stage for more than 3 to 5 years. Usually, a rough estimate is there are 5 stages. Start with unilateral, that may be about 3 to 5 years. Then it becomes bilateral trauma, another 3 to 5 years. Then you develop a postural instability, third stage, maybe another 3 to 5 years. Fourth stage is something like florid one. All the features are there. That again 3 to 5. Finally, one becomes confined to the wheelchair, and that can go on. And most of the time, when you reach the stage 5, if you go by this way, it may be about 15 to 25 years. Thereafter, it doesn't mean that when you reach the stage 5, it's the end of it. You just have to continue with taking care of avoiding infections and avoiding contractures, avoiding all those comorbidities, and life can go on. That's one part of it. That means it is a progressive disease, but it's a very slowly progressive disease. There's a lot of hope to go on for a longer time. So it doesn't mean that something is around the corner, number one. Number two, the advances in the treatment of Parkinsonism is fast, I would say, in terms of development of diagnosis and our understanding as well. What I'm trying to say is, people start talking about or thinking about or suspecting about whether one has got Parkinsonism or not. The hallmark of the disease is the hypokinesia. What I mean by hypokinesia or bradykinesia is slowness. If one of your family members, if you notice them, especially the elderly people, he gets slow. It takes a longer time to do the things which he used to do faster in the past. Then one should suspect. Hypokinesia is the hallmark of it. But that is already a stage wherein it has progressed to an extent. You add to it the tremor as well as rigidity, and this is the triad. And after some years, the postural instability and falls will come. All have been told very nicely. But there are now certain symptoms I mean, one of the important thing and the interesting thing about Parkinsonism, the latest thing is there is what is called gut-brain axis. What I'm trying to say is we have good bacteria as well as bad bacteria in the gut. We call that. So we use a lot of probiotic to enhance or to encourage the good bacteria to grow, good organisms. These organisms are connected to Parkinsonism in some way. The recent research is pointing towards it. They produce a certain type of inflammation. And you all know that this gut is supplied by a parasympathetic nerve called vagus nerve. So this inflammation ascends up along the vagus nerve to the lower part of the medulla. So first thing to involve, so there are certain, from the lower part of the medulla or the dorsal nucleus of the vagus, then it goes up to involve the rest of the extrapyramidal system as well as the cerebral cortex. So before the typical signs of the hallmark signs of hypokinesia and tremor appear, there are certain signs which can be traced to the involvement of the dorsal nucleus of the vagus as well as lower down. I would particularly mention two important symptoms. One is anosmia, that the person loses the ability to smell. The second one is very interesting one. We call it sleep enactment or rapid eye movement behavioral disorder, RBD. What is it? Normally when one dreams, when one sleeps, he can have a lot of dreams. Some dreams are pleasant. Some dreams involve violent scenes. But when it involves violent scenes like kicking, you don't really kick because the brain already has sent a message to the motor part that you sleep. You are not going to get activated. So this sort of cross connection, crosstalk is disturbed in Parkinsonism early in the stage. So if that person with Parkinsonism, when he sleeps and dreams, if he has a violent dream, he may actually kick the partner who is sleeping with him. This is what is called sleep enactment. They act on the dream, which is not the usual way. So these are certain things which can tell us that if we follow these people closely over a period of time, most of them will develop. Parkinsonism doesn't mean I'm trying to say that everybody who has got a loss of smell will eventually develop into Parkinson's disease. A small percentage. In other words, anosmia can be a premonitory symptom which is worth to follow up. Right? The reason why I'm telling all these things is it is now possible. Research is going on those areas wherein you are trying to identify the premonitory signs, the prodromal signs or symptoms, which can foretell you these patients are likely to develop Parkinsonism later. That's one aspect of it. The second aspect of it, there are now, we have talked about the standard drug pharmacological treatment, levodopa and levodopa-carbidopa combination, and then we have the dopamine agonist, then anticholinergics, then the inhibitors of the system like MAO, monoamine oxidase inhibitor, the COMT, catecholamine methyltransferase activity inhibitor. All these are standard drugs, including the latest adenosine 2 receptor antagonist, istradifilin, right? But now there are certain drugs like selegiline and rasagiline, or some of those dopamine agonists. There are a number of drugs available in this group on an experimental basis. These drugs can really modify the course of the Parkinsonism. In other words, we are trying to find out signs which can tell us in advance the likelihood of a person going to develop Parkinsonism on one area. The other area, we are trying to develop drugs which can modify the course of the illness. So if you are successful in these two areas, then we can identify people at a much earlier stage and start these drugs and modify the disease so that they don't go into the typical stages of the 5 stages which I told you earlier. So research is going on these areas, and it's very promising. So good news is, I would say, not far away, it's around the corner.
Thank you, Dr. Sethuraman. There's another question whether vitamin B1 can be used in treating restless leg syndrome.
Oh, okay. You're talking about vitamin D.
Yes.
Okay, vitamin D has got a very definitive role in another disease, the multiple sclerosis. It's a vitamin D deficiency that certainly leads to more severe disease, and it has been shown that the deficiency of vitamin D is a part of that one. So it helps over there. But so far in Parkinsonism, I have not come across something connecting vitamin D with Parkinsonism. Non-steroidal anti-inflammatory agents, yes. Gene therapy, cell-based therapies, like transplantation, number of things are going on. But vitamin D I have not come across anything on the literature. Have you?
None. What about vitamin B?
B1, B6, B12 are called neurovitamins. So it can be used as a supplement, but I don't think it has got a definitive role.
Right. Yeah, there's a question from Mrs. Jagdishwari again. She asked, why is there no doctor's advice on any vitamin? And I think you more or less answered that. Yeah. Are there any other questions? We'd like to apologize because you overshot the session by 20 minutes. Okay, if I don't see that there are any more questions, is there anything that you'd like to ask?
No,
hello.
All the things.
This is Mrs. Leong. No, not a question, but I'm from the Parkinson's Association. So just want to say thank you to the IMU organizers and also the presenters, and also to Dato and to Doctor for the very useful information and tips on Parkinson's. Also, thank you to all the participants for dialing in today. And I hope you have picked up good information to take back for you to manage your disease. So thank you, presenters and organizers. Thank you.
Thank you, Mrs. Leong. Thank you so much.
Okay, so I'm B from IMU, and this concludes our presentation. I would like to apologize for our participants on behalf of my team for our technical issues. Firstly, we would like to bring your attention to the short feedback form for this session. We would appreciate it if you could devote your valuable time to reflect on this informative session. The link to the form will be sent in the chat box. Now, I would like to extend my heartfelt gratitude and appreciation to all the individuals who have contributed to this session. First and foremost, I would like to thank the participants of this seminar for being patient while we experience technical difficulties. Your presence and participation demonstrate your genuine concern for understanding Parkinson's disease and improving the lives of those affected by it. Next, I would like to express my thanks to our project leader, Muhammad Ibrahim Khan, for his exceptional leadership and dedication, my peers from Group 12 from IMU for their collaborative efforts, and our advisor, Dr. Sunil Venkateswaran, for his guidance and unwavering support throughout. I would like to express thanks to our esteemed speaker, Dr. Seturaman Nagapan, for your efforts to spread awareness of Parkinson's disease despite technical issues and answering the questions for our audience's concerns. Last but not least, a heartfelt thank you goes to our representative from the Malaysian Parkinson's Disease Association. Your presence and insights have shed light on the challenges faced by those living with Parkinson's disease. Your organization's tireless efforts in providing support, resources, and advocating for the rights of the Parkinson's patients are truly remarkable. Thank you. This is the end of our presentation. Thank you for listening.
Thank you. Thanks.
Thank you, everyone. Have a nice day and take care.
Thank you, everyone. Have a nice day. Thank you, Winnie, for the concluding the session as well. Thank you.
Thank you, Doctor. Thank you, Doctor, and thank you, Ibrahim, for the session. Thanks, everyone, for coming as well.
Yes, thank you, Dato. Thank you, Doctor, and also Muhammad Ibrahim. It was a good session for us. Thank you very much.
Most
you.
welcome.
Namaste.